hasn't undergone a sex change. I am Dr. Kohli representing him here this afternoon. I just want to take you very briefly through the laboratory diagnosis of Pheochromocytoma, after which my colleague will go through infertility. Okay, so Pheochromocytoma basically evolves from the adrenal medulla. The adrenal gland has two sections, the cortex and the medulla. The medulla is responsible for the formation of the catecholamines, epinephrine, and norepinephrine. This is just a diagram showing or reminding you about physiology, the biosynthesis of catecholamines, and of course the degradation after action at the neurosynaptic junction. I won't go through it. So what is pheochromocytoma? It's a tumor of the adrenal medulla or the autonomous nervous system. It produces catecholamines, adrenaline and noradrenaline. Of course, this leads to the specific signs and symptoms of an increased heart rate. One can have headaches, pallor, sweating, high blood pressure. Any symptom that can be associated with an increase in the catecholamines, one can expect it to be associated with pheochromocytomas. Now, the characteristics of pheochromocytomas, if you remember the rule of tens, 10% are extra-adrenal. Studies have shown that this percentage is actually higher at 15%. 10% are kind children, 10% are familial, 10% bilateral or multiple. They can recur, they can be malignant, and 10% are usually discovered incidentally. The familial causes, the ones which I want to highlight, the most important, of course, are the MEN syndrome, specifically the MEN2 syndrome, either 2A and 2B, dependent on what other endocrinology abnormalities accompany it. Of course, 50% of PHEOs also occur in von Hippel-Lindau syndrome. You can have your familial paragangliomas also associated and your islet cell tumors also associated. The main point I want to make today from a laboratory perspective about pheochromocytomas is, of course, the biochemical testing. There are a number of laboratories that still continue to do both plasma testing as well as 24-hour urine testing, and we get a lot of queries about why we don't do plasma testing, even though it's a simpler test, less cumbersome than 24-hour collection. And the reason is simple. We look more at the specificity of the test rather than the sensitivity, because you can have an increase in your metanephrines, and indeed even with your urinary catecholamines and metanephrines due to a lot of other causes, especially medications, and especially antihypertensive medications, which most of these patients are actually taking. So for the simple reason of the high specificity of 98%, we decided that we will do only the 24-hour urine testing. Of course, stimulation testing can be done, hardly done anymore because of the complications that can arise. Two main types of suppression and, well, one suppression test, one stimulation test. The complications are serious. With the clonidine suppression test, hypotensive shock is a problem, and with the glucagon stimulation test, hypertensive crisis is a problem. These are no longer routinely done unless, of course, there's diagnostic inaccuracy or it's not very clear as to what the patient may have, and then we can attempt to do the dynamic tests. Imaging, not my area of expertise, so I'm not going to discuss it much, but there's a lot of imaging that is available in terms of CT scans, of course the radionuclide scans that are now available. The next slide is just not very clear, but it's just a diagrammatic representation of what one can do when working up a patient with suggestive pheochromocytoma. Of course, the first line is to look at the actual products, the catecholamines, measure them and see if they're markedly high. Management is of different patterns. Of course, it's a multidisciplinary approach. One has to look at the patient at different levels, pre-operatively, intra-op, and of course post-operatively as well. In specific groups of patients, like in pregnant patients, one has to be more keen on how one controls their blood pressure, both before, during, and after the surgery. And of course, mortality rate is also higher in pregnant women. I'm not going to discuss management because I wouldn't be able to tell you what to do when it comes to operative. Finally, this is my last slide. What I want to highlight is that with the current management, with the current diagnosis, mortality for pheochromocytoma has gone down significantly. 60 to 70 years ago, it was almost 50%, but currently it's down to 2.7%. What could this be due to? Of course, a better understanding of the disease, better pre-operative preparation, better alpha blockade, newer anesthetic techniques and modalities, better intraoperative monitoring, and most importantly, I think, using a multidisciplinary, experienced and coordinated teams, including endocrinologists, anesthesiologists, and of course, the surgeon. Thank you. I now hand over